Welcome to this PCR e-course on TAVI patients and procedure in 2020 and beyond, leading with Evolut platform. So the learning objectives are to learn about the different needs of TAVI patients with longer life expectancy and how to meet them, and also to learn about the importance of hemodynamics and DVI correlations to mortality in TAVI patients, and finally to learn practical procedural tips and techniques to achieve superior outcome and early discharge in a changing TAVI patient landscape. My name is Lars Søndergaard. I'm a cardiologist in Copenhagen in Denmark, and it's my great pleasure to be joined here by Nicolas from Mieghem from Rotterdam in the Netherlands and Didier Tchétché from Toulouse in France. So let's start with the first talk here by Nicolas, who will talk about hemodynamics and DVI correlations to mortality, what we need to know. Nicolas, please.
Thank you very much, Lars, for the nice introduction. So I will be discussing the hemodynamics of transcatheter heart valves and hemodynamics as expressed by Doppler velocity index and its potential correlation to mortality. These are my conflicts. And as a background, we all know that TAVI with a self-expanding bioprosthesis with a supraannular valve functioning has superior forward flow hemodynamics, including low mean gradients, larger effective orifice areas, and an increased Doppler velocity index that may also translate into lower rates of patient prosthesis mismatch. There may be an association between severe patient prosthesis mismatch and adverse outcomes. But if you then look at the literature, there is a variable association, and potentially this can be attributed to miscategorization bias due to challenges in measuring the LVOT by echo. That is where Doppler velocity index come into play, because it's a measure of obstruction that is defined by the ratio of the VTI in the LVOT to the aortic valve, and it provides a more reproducible measure as compared to the effective orifice area. And this is basically what you need to know about these Doppler velocity indices. So if you remember the continuity equation, then the valve area, or basically the stroke volume that goes through the LV, through the LVOT, should also go through the aortic valve. So by the continuity equation, then the valve area times the aortic valve VTI is the LVOT area times the LVOT VTI. And then it becomes a simple math. The valve area is the LVOT area times the LVOT VTI divided by the aortic VTI. It becomes very easy then, because from this, you just do simple mathematics, and then you have the Doppler velocity index, that is the ratio of the LVOT VTI to the aortic valve VTI, which also equals the aortic valve area ratio to the LVOT area. And this means that, for instance, what we all know, if the Doppler velocity index is 0.25, so that means that the valve area, the aortic valve area, is a quarter of the LVOT area. So what is a typical LVOT area? If you have a radius of 1 centimeter or an LVOT diameter of 2 centimeters, then more or less your LVOT area will be 3 centimeters square, or 3.2 centimeters square. So if you take a quarter of that, you are at 0.75 centimeters square. And this is exactly one of the cutoffs to talk about severe aortic stenosis. If that ratio is 0.3, then you arrive to 1 centimeter square, 3.2 divided by 3. So this is basically what you need to know about Doppler velocity index. So we looked into the Doppler velocity indices in patients who were treated within the TAVI randomized trial. We had over 1,000 TAVR patients and almost 1,000 surgical aortic valve replacement patients. Then we looked at what was the resultant Doppler velocity index for each treatment arm. Maybe as expected, the majority of the patients in the TAVI arm had a Doppler velocity index above 0.5, whereas in the SAVR arm, in the surgical arm, that was the opposite. So that means that in surgery, the aortic valve, after the valve implantation, had an area that was less than half the area of the LVOT, whereas that with TAVI, with the supraannular valve, with the Evolut system or a core valve system, it is more than half of the area of the LVOT. And this is a recent paper by Mieghem that helps us estimate what the Doppler velocity index would be with an Evolut valve. And this is the lowest row. You can see that basically above the valve of 23 millimeters, so if you use an Evolut of 26 to 29 and even take the XL, then basically the Doppler velocity index will remain the same and will be around 0.6, which is a high number. So does that affect then the functional status of these patients? And this slide summarizes at baseline, so pre-discharge at 1 year and at 3 years, baseline, sorry, 1 year and 3 years. And then you can see that the functional status of these patients in terms of New York Heart Class was not different according to the Doppler velocity indices, not for TAVI, not for surgery. But if you look at quality of life, then we know that the quality of life improves faster in the TAVI patients as compared to the surgery patients, regardless of the Doppler velocity index. So no impact there in terms of quality of life improvement. But then if you look at all-cause mortality at 3 years, all of a sudden you see something happening. And in patients with a Doppler velocity below 0.5, there is a clear increase in mortality. And this increase in mortality was happening both for the TAVI patients and also for the surgery patients, where you can see that in blue, those were the patients with a Doppler velocity index less than 0.5. Those patients had a significantly worse outcome in terms of mortality. So if you then compare Doppler velocity indices for different valve types, and I think the most commercially available valves are either a balloon expandable valve or the self-expanding supraannular functioning Evolut system, whereas the balloon expandable is intraannular, well, that has some consequences in terms of the Doppler velocity index. With a balloon expandable valve, the typical estimated Doppler velocity index will be below 0.5, whereas with Evolut, it will be typically above 0.6. And these are quite interesting findings. So in conclusion, you might see that flow obstruction as measured by the Doppler velocity index, when it's below 0.5, it occurs more frequently with surgery than with TAVI, with the self-expanding supraannular functioning valve. It is associated with higher mortality at 3 years in the SURTAVI trial. It does not seem to affect quality of life or functional status, but it is intriguing that with the supraannular valve, the expected Doppler velocity index is the best in class and definitely higher as compared to intraannular functioning valves. But we do need further study to define the significance of the Doppler velocity index after TAVI and SAVR, and also its impact on outcome, especially in terms of transcatheter heart valve durability, which we will be discussing later today, between the different valve platforms. So with that, I would like to give the word back to Lars.
Nicolas, that was an excellent presentation with also some novel data I haven't seen before. So it seemed that there's a move from what we used to talk about, patient with severe patient prosthesis mismatch, towards using the DVI instead of. Can you just try to explain what is the difference between those two ways to assess the valve after the procedure?
Yeah, I think that is a very relevant question to our practice, because these indices, they reflect the valve performance, the hemodynamic performance of the valve. But the issue with patient prosthesis mismatch is that by definition, it requires the effective orifice area of the valve after it is implanted. But by the formula, you need an exact assessment of the LVOT diameter, because you rely on the continuity equation again. And this becomes very difficult if there is a prosthesis in place. And the measurement will be different with a TAVI versus surgery. You have all these blooming artifacts, but also we all know that the self-expanding valve, it has a tendency to flare open a little bit, whereas surgical prostheses are very straight. Well, where do you measure then your LVOT and use that as the reference diameter? So turns out that there is a lot of variability in the measurements. So the inter and intra individual variability is quite high. So there is a big limitation to the measurement of the effective orifice area that relies on the LVOT diameters. You take that out of the equation with the Doppler velocity index. So it's a more robust parameter that is also more reproducible and basically has the same meaning because it will evaluate your hemodynamic performance.
Yeah.
And Nicolas, I had a question for you. How did you explain that for a given DVI, we had a similar improvement in terms of quality of life in both cohorts, and then we observed an increased mortality in one of the cohorts starting from the same point? What is your explanation for that?
Yeah, I think that is a very interesting observation, and we can formulate a couple of hypotheses. I think an important one that I believe makes sense is that when a patient faces a DVI below 0.25 because he or she has severe aortic stenosis and the ventricle has to work against that obstruction, and all of a sudden you partially relieve the obstruction by increasing the DVI from 0.25 to 0.4, for instance, then the patient will feel this. So the ventricle is partially unloaded, the patient will feel less symptomatic. If you then address this in a quality of life assessment, that might affect the outcome. But the ventricle is still facing some kind of an obstruction because the DVI is below 0.5. And this is where I think the effect on longer term outcome plays an important role. If the ventricle keeps on facing more than insignificant obstruction, being a DVI below 0.5, that will come to haunt the patient eventually. And that is, I think, why the patient becomes or faces a more reserved outcome down the stretch if the DVI is below 0.5.
Okay, thank you.
So Nicolas, you nicely explained that patients who after TAVI procedure have a low DVI seems to have a poor outcome. Is it any way possible to identify these patients prior to the procedure and maybe also take that into consideration when you're choosing one or another transcatheter heart valve?
I think we will need more granularity to understand who is at risk of getting a low DVI after TAVI. At this point in time, we don't have that granularity from, for instance, the TAVI trial because there was no CT core lab and we did not have an in-depth analysis of the CT scans. But I think it is intuitive that in patients where there is a lot of aortic root calcification, that the valve expansion, your bioprosthetic valve expansion will be less, and that might affect your DVI and will result in a smaller DVI. So my gut feeling tells me that the more calcium there is, the higher the risk for a low DVI. And this might be different for other valve platforms with a different radial strength or a different way of implantation design, but more research is needed to elaborate on that. I think in 2020, TAVI has matured to become a very robust strategy for patients with severe aortic stenosis across the entire risk spectrum. We have been facing an extraordinary situation with this COVID pandemic, and I think within that framework, simplifying TAVI and make it more lean, including optimizing techniques and also early discharge protocols, are the way to go. So with that in mind, I would like to give the word to Didier to express and to talk about his techniques to improve TAVI implantations, but also to affect early discharge. Didier.
Okay, thank you, Nicolas. So let's talk a little bit about procedural optimization and the new techniques, as you said, to achieve early patient discharge. Here are my conflicts of interest. So what do we have at early discharge? As you have all witnessed, we have seen a huge increase in the number of the procedures performed worldwide, and on a daily basis in some centers, you may have to treat 6 to 8 patients. And so meanwhile, what we've also seen was a decrease in the hospitalization state. So we had to find solutions to be sure that we can early discharge the patient, but on a safe manner. And this is really important. Early discharge has to equal safety for the patient. So there are several issues that we have to take into considerations to make sure that the patient is not going to have any complications once he gets back home. I'm not going to talk about perivalvular regurgitation because this is becoming less and less of a complication of an issue, particularly with sealing properties of the devices that we have now, like the wrap of the Evolut Pro, for example. And I would like to focus more on first vascular complication and preventing major vascular complications. CT scan is really the core of the assessment of the peripheral vasculature in terms of diameters, tortuosity, and calcium load. And we all know that the shift to femoral artery ratio below 5% is really mandatory to make sure that we decrease the rate of vascular complications for our patients. But something that we know more and more, and that has become real, is the fact that at close to 1/3 of the major vascular complications that we see originate from the accessory access that we utilize to guide the procedure. So we don't face major vascular complication from the large bore shift, but it's more from the 6 French shift that is implanted in the contralateral femoral artery. That's why we have developed, and more the centers are now coming to this type of setup with only one femoral access and one radial access. Here it's a 6 French long shift that is going to house a 5 French pigtail just to guide the procedure and to make sure, as we know, we have understood from the PCI history, we can clearly decrease the bleeding and vascular complication if we use the radial access. So it's going to become one femoral access, one radial access for a simple procedure. So you also see that we have some pacing system on the left side. On the left, the secondary access. I'm going to go through it afterwards. So one very important aspect of the procedure, and Nicolas, you were one of the really strong promoters of this type of puncture, was to move from the fluoro-guided puncture to the echo-guided puncture. And it doesn't require a very long learning curve. Here you can clearly see that you can nicely identify the location of the common femoral artery in that long axis view. And you can really tailor the anesthesia from the adventitia to the subcutaneous tract and then the skin of the patient. It increases the comfort of the patient, and really you can make afterwards a precise puncture. So here you're going to see that we can clearly identify the needle that is going to drive the wire and then the 6 French shift, and you can clearly target the top of the anterior wall of the common femoral artery in a location that is related to the common femoral head, and to be sure that in case of complication, bleeding, and need for manual compression, you made a safe puncture of the common femoral artery. So you do the tenting, and then you can rotate to the short axis and get access to the vessel. So a very simple, efficient, and contemporary way to get the femoral puncture done. So I'm not going to go a lot into details about the left ventricle wire stimulation. If you want to get details about that, you can go to my toolbox on the PCR Online website, and you will get all the tips and tricks, all the aspects of stimulation on the left ventricle wire. But the core idea is to prevent the right ventricular perforation that may occur with a right ventricular lead in some patients. So we've seen that preventing major vascular complication was a key part of the planning of the early discharge for our patient, but we also have to make sure that we are going to decrease the need for a permanent pacemaker. So through all the experience gathered, we now better understand what are the risk factors for the predictors for a need for a permanent pacemaker. And the strongest one are first the existence of the right bundle branch block at baseline, but also the depth of implantation. And we've seen that with all types of devices, and it's particularly true for the self-expanding Evolut platform. And here you see that if you deploy the device below 6 millimeters in regards to the aortic annulus, you're going to increase the need for a pacemaker for your patient. So we tend to go higher and higher, and now it's more recommended to be 3 to 5 millimeters below the annulus to make sure that the risk of pacemaker remains low for our patients. But how to achieve that in a more contemporary way? It's a kind of, I would say, a revival of the cusp overlap technique, because it's a very nice way to prevent conduction disturbances. And the idea of the cusp overlapping technique that was first introduced by Jean-Claude Laborde when he went for proctoring about the deployment of the core valve. Then it was brought back in front of the scene by Nicolas with the double S curve technique. The idea is to get both in the same plane, the annulus and the ring of the capsule, everything aligned without any parallax. And this is going to provide precision in terms of deployment, control of the final depth of implant, and it provides also consistency in terms of reproducibility of the deployment, particularly with the self-expanding Evolut. And it's quite interesting to see that in the centers that have adopted that technique, the final pacemaker rate can be below 5%, and 5% with that self-expanding platform is really a very, very strong outcome. It's a positive signal favoring early discharge for our patients. So probably that in a more contemporary way, the cusp overlap technique has to be implemented in daily practice. So ideally, you're going to predefine before the procedure what is going to be a nice cusp overlap view, and it's always an area or caudal projection. Sometimes it's a quite extreme caudal projection, so you have to make sure that you can safely deploy the device. And you're going to see that most of the time it's a combination of areocaudal to deploy and then moving back to the LAO projection for the final release. And you're going to elongate the left ventricular outflow tract in that view, better identify the length, the position of the membranous septum, and make sure that you deploy the device just in that region without being too deep and having too many contact with the conduction system. Here is a step-by-step description of the overlap, the cusp overlap technique. It's a kind of modified deployment sequence as compared to what we used to do before that technique came to us. So the first thing you're going to do is to start to deploy above the annulus in the areocaudal projection. And this way, you're going to make sure that you control the extrusion of the inflow portion of the stent frame, and you really tailor the final depth. And the more extrusion and expansion of the device we have, the more tension you apply to the system to be sure that you remain below between 1 to 1 to 3 millimeters below the annulus in relation to the non-coronary cusp. Then once you are at the final depth and you are happy with that, you have to move to come back to the LAO projection, to the free cusp view for the final release to understand the amount of tension that you have in the overall system. So this is a kind of combination of the areocaudal, and then you move to the LAO for the final release. So we've seen the importance of major vascular complication. Why do we move to that?
Time is up.
Sabotage. So it's only 30 seconds now. Ouais, vas-y, va sur la. Okay. So we've seen the importance of major vascular complication prevention and base conduction disturbances prevention, but it's also important, particularly in the frail population, the elderly population, to make sure that we have an early ambulation. So what we promote in Toulouse is patients standing up 4 hours after the procedure and walking the day after the procedure to make sure that we can safely have them going back home day 2 or day 3 after the procedure. So to conclude, to remember very simply, major vascular complication must be prevented in a contemporary way if we aim at early discharge for our patient. Single-digit pacemaker rates should be the target because it's achievable with the cusp overlap technique. It has to be a modification of the technique that we all master, and we have to keep it safe, 1 to 3 millimeters below the annulus to avoid pop-ups, for example. Early ambulation, to my opinion, is part of the optimization process, and early discharge is clearly achievable with the self-expanding Evolut Pro or Evolut RXL platforms. For having said that, I'm going to hand over to Lars. Thank you.
Didier, that was an excellent presentation. So it's really impressive to see how you have leaned the TAVI procedure and also the hospital stay in Toulouse. So what is, how long do you observe conduction subnormality before you make a decision for whether the patient needs a permanent pacemaker or not?
This is a very important point, Lars, and I have to say that within 2 days in Toulouse, we make the decision of implantation of a pacemaker or not. And it depends on the combination of the risk factors at baseline, the final depth that we obtained for the patient, and the length of the membranous septum. If we combine everything and we think that the patient is at high risk of delayed AV block because of a deep implant, a short septum, or LBB, right bundle branch block at baseline, we keep it under surveillance for 5 days. Otherwise, within 2 or 3 days, the patient is discharged.
So Didier, it is quite impressive to learn that by applying the double cusp overlay technique, that centers manage to reduce the pacemaker rate to single digits. But is there a flip side to that equation? So I would think if you would end up implanting higher, that might affect coronary accessibility. Can you briefly comment on that?
Yeah, I think it's a key question, Nicolas, and it tells us about the integrative approach that we must have for a single patient. That is to say that if we think that the patient is at high risk of requirement for a further coronary cannulation in the future and so on, we may avoid a too high implant that may impede coronary access. So it has to be integrated in the final decision, and it's a very, very important comment that you made. We shouldn't be focused only on pacemaker. It's we have to integrate every aspect: regurgitation, pacemaker, and coronary access, particularly if we move towards younger patients. So now it's my real pleasure to introduce you, Lars. You're going to drive us through what we know and what we don't know about life expectancy and durability of the transcatheter heart valves.
Thank you, Didier. So these are my disclosures. So I'm going to start with this trial. We have seen TAVI against surgical aortic valve replacement across all surgical risk strategies, from extreme risk down to low risk. What we have to keep in mind is that in all these trials, most of the patients who went in was quite old. So mean age was 80 years of age until we saw the 2 low-risk trials last year, where it came down to 74 years of age, but still elderly patients. But despite that, I think everyone expects that TAVI is not only going to move to patients at low surgical risk, but also to patients with longer life expectancy. So these are data from Copenhagen, and on the left-hand side, you see what the surgeons did back in 2005 and 2006. The black bars are those who received a mechanical valve, and the gray one, those who have a bioprosthetic valve. And the age of break-even was 68, and less than 10 years later, that came down to 61 years of age. So the surgeons hardly use any mechanical valves anymore. So we're going to expect that TAVI is going to take the majority of these patients who today are receiving a bioprosthetic surgical aortic valve, and instead is going to be a transcatheter bioprosthetic aortic valve. And that also means that we're going to treat patients with a much longer life expectancy. So we need to talk about lifetime management of these patients, and not only a short-term outcome in these elderly patients. And even though we don't know the durability of these transcatheter heart valves, but let us assume it's going to be around 10 years of age. And today, as I said before, the patient we're treating are around 80 years of age, and just assume these patients are going to live to the 85 years. So that patient have 5 years of life expectancy. So you're not going to see these transcatheter heart valve is going to fail, because the valve is going to survive the patient. But if we assume we're going to do the same as the surgeons are doing, going to treat patients at a much lower age, let's say down to 60 years of age, and that patient is still going to live to his 85. That patient had 25 years of life expectancy. And again, if the valve is going to last for 10 years, you can see that patient will need 2, maybe even 3 revalving during a life expectancy. So we have to take this into account when we talk about lifetime management to make sure that the patient receive a transcatheter heart valve which have a long durability to minimize the number of revalving during a lifetime. So just going back to the 2 low-risk trials, we know in partner 3, the valve which was used for transcatheter aortic valve replacement was the SAPIEN 3 balloon expandable valve with internal apposition of the leaflets, and the Evolut low risk, it was a core valve platform, the Evolut platform, self-expanding technology with a supraannular leaflet position. And we saw here that if you're going to the partner 3 trial, that the TAVI patient actually came out with a smaller efficient valve area and also a higher gradient than the patient who went for surgery. Whereas in the Evolut platform, it was with the Evolut platform in the Evolut low risk trial, it was opposite. Patient who went for TAVI came out with a significantly higher aortic valve area and a significant lower mean gradient than the patient who were treated with surgery. And we have, even though these patients was not randomized, we have now seen the 5 years data from the CHOICE trial, which randomized patients to the SAPIEN and core valve platforms. And again, even at 5 years, you see, you're looking at the mean gradient, there's a constant higher gradient in the patient who have a balloon expandable valve than those who have a self-expanding valve with a supraannular position of the leaflets. And again, that's probably also going to turn into severe patient prosthesis mismatch. So where in the partner 3 trial, there was no difference in the rate of severe patient prosthesis mismatch between transcatheter and surgical aortic valve replacement, it was quite high, 8 to 9% of the patient. There was a clear difference with the Evolut platform in the Evolut low risk trials, much lower rate than with in the TAVI patients. So talking about durability, we have to use a standardized definition. In 2017, we saw this European consensus talking about valve dysfunction and valve failure. And for the valve dysfunction, maybe the most interesting part is to talking about structural valve deterioration with a high gradient or a central leak of these valves. And we now have seen up to 6 years data for structural valve deterioration with the core valve platform. And we can see that at 6 years, the rate was much lower for structural valve deterioration with the core valve platform, 1% compared to 12% in the surgical cohort. And at the same time, we have seen data from the partner 2 trial at 5 years. Again, with the SAPIEN platform, the rate is not lower, but it's higher in the TAVI cohort compared to the surgical cohort. And moving from valve dysfunction to valve failure, defined as severe structural valve deterioration, the need for valve reintervention or valve-related death. And again, applying these criteria to the NOTION trial with the core valve platform, at 6 years, it was the same rate between surgery and TAVI, quite low, around 7%. Whereas in the partner 2 trial with the SAPIEN platform, we saw that the patient who underwent TAVI with a balloon expandable valve, there was a much higher rate of valve failure at 5 years. And again, this may, as we discussed early on in this session, impact the outcome of the patient. So going back to the CHOICE trial at 5 years, SAPIEN versus core valve platform, if you look at cardiovascular mortality, it's about 50% higher in the patient who was treated with the SAPIEN platform, around 30% compared to around 20% with the core valve platform. So just to conclude here, durability of bioprosthetic aortic valve is important, particularly as we now expect to move to patients with longer life expectancy. And also we have seen consistently that self-expanding transcatheter heart valve with supraannular leaflet position offer larger opening area and lower transvalvular gradient, and that this may turn into a lower rate of structural valve deterioration and valve failure as compared to balloon expandable transcatheter heart valve, and surgical bioprosthetic aortic valves. And similar, that lower rate of severe patient-prosthesis mismatch with the self-expanding transcatheter heart valve may improve the survival rate after TAVI.
Okay, Lars, that was a very compelling presentation. What I always ask myself is about the elephant in the room, at least with surgical bioprosthesis. We know that the younger patients are, when they get a bioprosthesis implanted, the faster the degeneration process occurs. Do we have some signals there with TAVI as well? So meaning that if you get your valve at a younger age, that these TAVI valves will degenerate faster?
I don't think we have any specific data on the transcatheter bioprosthetic aortic valve, but as you say, we certainly have it on the surgical bioprosthetic valve, where we know that if you put these valves into elderly patients, they're going to have a longer durability than if you use them in younger patients. And I think that's also why, if you look at the European guidelines, that the cutoff between a mechanical valve and a bioprosthetic aortic valve is around 65 years of age. But we also know that that's not respected anymore. Surgeons are putting these bioprosthetic valve into much younger patients, probably driven by that the patient doesn't want to go on anticoagulation therapy, and also have the idea that when this surgical valve is going to fail, you can just do a valve-in-valve procedure, put a TAVI valve into it. So, but I think certainly we need to have that into consideration when we treat these patients with longer life expectancy at a younger age, that if you start with a bioprosthetic aortic valve, it's going to have a relative shorter durability than if you use them in these elderly patients we have done so far.
So that's a very important point, because as you may have noticed, there is a quite vivid discussion about the sequence that we may adopt, because we now have the indications for TAVI in low-risk patients. But what is a low-risk patient? Is it a low risk in 70 or 80, or a low risk 60? If you have a 60-year-old patient, do you think that we could start with TAVI, then go for surgery, then go for valve-in-valve, or are there other factors that we need to make the decision?
That's a very good question, Didier. And we're talking about a lot of these sequences when we have to look at the lifetime treatment of these patients. So let's say you're going to start with a surgical bioprosthetic aortic valve, which has been done so far. We all know that we can do a TAVI procedure in these patients. There may be a risk of coronary occlusion, but we can handle that with the basilica or the chimney stenting. But on the other hand, we also know that the patient who receive a small surgical valve with patient-prosthesis mismatch are those who are prone to fail early on. And even we can do fracturing with when we do the valve-in-valve procedure, fracture the ring of the surgical valve, we're still not really getting rid of this patient-prosthesis mismatch. So another suggestion has been to start when, let's say, the patient is 60 years of age, do a TAVI procedure. When that valve is going to fail, when he's 70 years of age, you do open heart surgery, explant the TAVI valve, and implant a surgical valve. And if eventually that surgical valve is going to fail, you can do a valve-in-valve with a TAVI procedure. I personally just think that the patient who at age 60 with very little comorbidity is going for a TAVI procedure and local anesthesia, 1 hour procedure, going home the day or 2 days after the procedure. When he's 10 years older with more comorbidity, I'm not sure he's going to sign up for an open heart surgery and a heart-lung machine, a week or 10 days in hospital and 3 months of rehabilitation. And also for some of these valves, it maybe not just be a simple surgical aortic valve replacement. I mean, that can be ingrowth of the stent frame, and it may involve complex aortic root anatomy. So I think it's hard to stop this. I think the patient is going to ask for a TAVI procedure for the first time of revalving, and then this is going to fail. He wants a TAVI in TAVI. That's my best guess. And we have to make sure that the TAVI valve we choose in the first instance is suitable for a revalving that can be tried to work on commissural alignment to facilitate access to the coronary arteries and so on. But again, it's a shift between just looking at the short-term outcome. We want to offer a efficient and safe procedure to now to move to look at the lifetime management of these patients.
I think it's time to wrap up the session. I have to say that I took a lot of fun discussing with you guys. And what did I learn today? I learned that there is not a new tool, but the DVI comes back, and it may be something that we have to implement in our practice to better address the outcomes of the patient and anticipate who's going to have a real improvement in terms of quality of life, and more importantly, in terms of survival post-procedure. And we also discussed about the ways to optimize the procedure for early discharge, and that issue of prevention of coronary difficult cannulation for the future, particularly if we move towards lower risk and younger patients, is really important. But we may achieve single-digit pacemaker rates, and that is acquired, that is true with the cusp overlay technique. This is something that we have to take into consideration, but it's not the only item. And at last, the durability issue, because we are now moving not only focusing on the peri-procedural aspects of TAVI, but more on what is going to occur for the lifespan of the patient. And durability is certainly something that we have to consider. And the issue of treating younger patients, which sequence are we going to start with? It's going to be part of a quite vivid discussion in the coming months and years. And I was really pleased that we tried to address that, but we're gonna learn more and more in the future. So I hope that you enjoyed that. I would like to thank you guys, because personally I learned a lot from you, and I have to say that it was a real pleasure to be here with you.